Hello, everyone. Welcome to today's live broadcast of the Keynote presentation, Using New Technology to Control Healthcare-Associated Disease. I am Bob Woodard of LabRoots, and I'll be your moderator for today's event. Today's webcast is presented by LabRoots.com, the leading social media site for science professionals, and sponsored by Roche Diagnostics. As a global leader in healthcare, Roche Diagnostics offers a broad portfolio of tools that help healthcare providers in the early detection, prevention, diagnosis, and treatment of diseases. In molecular diagnostics, we are driven by a vision of working with laboratories like yours to improve the medical value you offer in microbiology, infectious disease, oncology, and genomics. We continue to meet unmet needs through our investment in research, innovation, and scientific excellence with the goal of supporting your important role in improving patients' lives. Before we start, there are a few instructions. We want to hear from you during this interactive broadcast, so please ask questions or leave us a comment. Answers are welcome too. You submit your questions by clicking on the green Q&A button at the lower left of the presentation window and typing in your comments and questions. We'll try to get to as many as we can, and we'll follow up if we don't have time today. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have technical difficulties hearing or seeing this presentation, let us know by clicking on the support button on the top right or use the Q&A button, and we'll do our best to help solve the issue. Now let's get to today's presenter, Dr. Lance Peterson. Dr. Peterson is the Director of Microbiology and Infectious Disease Research, Vice Chair of Pathology for Research, and Epidemiologist at NorthShore University HealthSystem in Evanston, Illinois. He is also a clinical professor at the Pritzker School of Medicine at the University of Chicago and a staff member in the Clinical Microbiology and Infectious Disease Divisions at Evanston Hospital. Dr. Peterson received his MD degree from the University of Minnesota and is certified in internal medicine, infectious diseases, and medical microbiology. Dr. Peterson's research interests have included the study of infections in the extremities of diabetic patients, investigations of antimicrobial agents in models that simulate closed space, neutropenic infections, and the epidemiology of nosocomial pathogens. The development and evaluation of molecular diagnostic testing, measuring activity of new antimicrobial compounds against bacteria and fungi, and the study of molecular mechanisms for the resistance of Staphylococci and pneumococci to the new fluoroquinolone antimicrobial agents. Current research activities focus on using molecular testing methods to enhance infection control activities, understanding the regulation of antimicrobial agent resistance in Staphylococci and Enterobacteriaceae, designing novel strategies for the treatment of infections due to resistant bacteria, testing innovations to reduce catheter-related bloodstream infections, and developing new diagnostic tests for rapidly detecting antibiotic-resistant bacterial pathogens. He has over 700 presentations, and is recognized in the 21st century editions of marquee Who's Who's. Please join me in welcoming Dr. Peterson to today's event. I'll now turn the presentation over to him.
Thank you, Bob, and hello, everyone. With the rapid advent of new technologies, one of the issues we're all faced with is bringing these into our hospitals, and challenges arise from, do they help the patient, and are they affordable, are they cost effective? And what I'd like to talk about in my presentation today is using two key example organisms, because they really have different models for both their benefit and their cost effectiveness. And we'll get started with the presentation. These are my potential conflicts of interest. Our laboratory works with both industry and government in developing new technologies and assessing their outcomes. So what I'd like to cover today is to review the problem of methicillin-resistant Staph aureus, or MRSA, and Clostridium difficile infection, specifically in the acute care hospital setting. also discuss the impact of infection control management on these infections and increasing the benefits to the patient and decreasing healthcare costs. And finally, discuss a little bit about what you can do at your own hospital to really determine or assess if you have a problem and some potential interventions that you can implement if you find that you do need to enhance your activities. There are several global issues in infectious diseases, and they're listed on this. The top two, MRSA and Clostridium difficile, are what I'll cover today. The first thing to remember is that MRSA infection is a human problem. It can cause severe disease. This is a young woman from Texas who had a very severe facial infection with MRSA, and she's posted a YouTube video. You can look on the link that's on the slide here, and she will tell you her story, which I think is very honest and open, that she's shared it with all of us. So one of the continuing questions is, should we continue to care about MRSA? Is it controlled? Isn't it controlled? The state of Illinois publishes on a public website a report card on how we're doing, and this is from the most recent report card from data through 2012. And the tall bars there look at what's happening as far as MRSA infections occurring in hospitals across the state through 2012. And you can see from 2009, 10, and 11, it looked like the rates were going down, but then 2012, the rates were going up. I've plotted our NorthShore rates on the lower, shorter bars just to show that it is possible to dramatically reduce MRSA infections in a healthcare system with appropriate approaches. And you'll see the same thing in Europe. So this is data from the European website in the European Union, published from 2009 data. And we'll look at the next slide, and you'll see that some of the countries have gotten better and some have gotten worse. So I do think that in reading the literature, it will be somewhat heterogeneous, but clearly there's a lot to do. And here's the 2012 data from Europe, again showing some countries have improved their situation regarding MRSA and some have not. So how does one become infected? What's the risk of MRSA infection, and what really leads to it? What perhaps can be useful in prevention? This is a slide from some work that was done at our facility, looking at almost 200,000 patients who had surveillance testing done. And the three groups represent patients that were PCR positive as well as culture positive in the nose for group 1. Group 2 were PCR positive only and culture negative for MRSA, and then group 3 were both PCR and culture negative for MRSA. And this looks at the MRSA infections that occurred in these groups over 1 year. And you can see that for those that were both PCR and culture positive, their rate of infection was 8%, more than 10 times higher than for those patients that were negative. The group 2 patients that were PCR positive and culture negative is intermediate, and what we found in looking at this is that some of the PCR positive, culture negative in the nose are culture positive elsewhere, such as in the throat or even the rectum. So this does represent some patients that are carriers of MRSA, but don't have to be culture positive in the nose. And the takeaway from this is that the greatest risk for MRSA infection is becoming colonized with this organism. So when we look at colonization and want to prevent it, there's been some very interesting work suggesting on how MRSA is spread throughout a healthcare system. And whole genome sequencing has been used as one of the novel investigations, and this looks at a 10-month study in a neonatal intensive care unit. They started active surveillance after they had 4 infections, and typically when you have an infection, you'll have 8 to 10 additionally colonized individuals in the nursing unit. And they compared several different typing systems whole genome sequencing, very common one, with common ones like pulse field gel electrophoresis and SPA typing. And they found that whole genome sequencing was actually the best in defining clusters. They had 5 instances in 2 clusters, and 10 of the cases were unrelated. And whole genome sequencing suggested 2 different ways that this transmission was happening. One was when the infants were close to each other, suggested healthcare workers, but it also suggested that there was repeat introduction of MRSA strains, which might suggest coming in from the parents. This is often difficult to talk to parents about because we don't want to make them feel guilty if really they have nothing to do with MRSA showing up or occurring in their babies. And one of the questions coming out of this, was there any immediate benefit of the whole genome sequencing over pulse field gel electrophoresis? And the reason for the question is whole genome sequencing is a lot more expensive than pulse field gel electrophoresis. Another interesting article that looked at epidemiology in a different way is looking at what's called close proximity interactions and at spread of MRSA in an entire facility. And what they did was using healthcare workers and patients. They were both cultured weekly, but they also had the healthcare workers wearing wireless sensors. And this is becoming very common on nursing units, and they measured their location every 30 seconds. They found during this transmission surveillance study in a nursing home, there were 173 transmission events, and they did find clonality. And what was interesting, when they looked at the whole nursing home, not just a given unit, 98% of the new colonization events had a close proximity intervention pathway, suggesting that actually spread was being done by healthcare workers. And there's an example of this on this graph from the paper. And what you're looking at here, the diamonds represent patients, the triangles healthcare workers, and then the different colors inside each of them are a given clone or non-colonized patients. And if you trace the healthcare movement around, you can see that healthcare workers are very efficient at picking up MRSA from colonized patients and even transiently colonizing other healthcare workers and then spreading clones throughout an entire healthcare hospital, or this happened to be a nursing home. So I think when we look at the epidemiology, we need to look beyond just one nursing unit and look at the whole facility in order to really come up with clear ideas as to what's causing spread. And again, keeping in mind that spread is what we want to avoid, because that seems to be, and the literature supports in many, many studies, the best way of preventing disease. So there have been several guidelines published over the years on what to do for control of MRSA. This is the latest one from the Society for Healthcare Epidemiologists of America, or SHEA. And you can see that the first thing we're all supposed to do is determine if we've effectively controlled MRSA, and I'll talk more about that later. But if we haven't, there's some special approaches that can be considered, and the 2 main ones are conduct active surveillance testing, or AST, for MRSA colonization, and then make sure that the compliance is being followed, and then implement decolonization as a second option, targeted therapy for those that are positive, or universal decolonization among high-risk patients. So these are just 2 ideas of things to try, and then again monitor outcomes to make sure you're having an impact. And this is what we'll talk about next. So this was our MRSA screening program that we started August 1st of 2005. So we just passed our 10-year anniversary. And the intervention was to do active surveillance testing on admission. And the goal was to assure that new admissions that we were doing our best so that they would not get MRSA if they didn't already have it. We had a high threshold for compliance. We made the ordering very easy, a single click in the electronic medical record for the MRSA admission screen. And then those that were positive were put into contact precautions, and initially decolonized. We've subsequently quit decolonization because we found the contact precautions alone are satisfactory for stopping transmission. And then for those that were decolonized, we made it easy, again, just a single order or single click to order the package of nasal mupirocin twice a day for 5 days, along with chlorhexidine bathing, and that was given on day 1, 3, and 5. And this program actually achieved a very prestigious award for our healthcare organization, the Eisenberg Award. Excuse me. So these are our results. On the far left bar is the baseline data, our MRSA disease rates in the year before we started. The second from the left, between the two arrows, is we actually did the program first in the intensive care units at our 3 hospitals, and that had some reduction in disease, but it was not statistically significant. We only saw statistically significant reduction in disease once we started doing all nursing units, and very quickly we saw more than a 65% reduction in infection, which is typical for a successful infection control intervention. One thing to keep in mind is that if you found something that works with infection control, usually you'll see a benefit very quickly. And this continued on over the next several years. And you can see that we've had a sustained more than 70% reduction in MRSA disease during hospitalization, and we even count 30 days after discharge. So we're using a very liberal definition of MRSA disease. And in our 4 hospitals now, we range from 2 to 3 bloodstream infections for all 4 hospitals combined per year. So very, very low rates of MRSA clinical infection. So a question to ask, and when I do things in person, we often discuss this. But these are different approaches to active surveillance or not doing active surveillance that are used throughout the United States. Most hospitals in the United States now do some active surveillance testing. Many of them do it in the intensive care units, and many states have mandated that to be done. But even if you're doing it in your intensive care unit, it's important to monitor the outcome and make sure that you're having the impact that you're desiring. This is the data from the Veterans Administration in the United States with about 160 hospitals throughout our country. And they started about a year and a half after we did. So they started in 2007, and they're doing active surveillance testing on all hospital admissions and actually also on all transfers and all discharges within their hospitals. And you can see what's happened here is they're continuing to see more and more nursing units where that go for an entire month with no MRSA infections, and that's what this plot is. And you can see that they've gone at the start of their program from about 50% of their nursing units to in the next by 2010 to almost 70% of the nursing units without an MRSA infection in a given month. And this is actually very, very dramatic for a healthcare system that deals increasingly with older patients and with patients with disabilities. So this has been a very, very positive thing for our Veterans Administration. This is another more recent publication of theirs from 2013 and 2011, looking at sustained transmission and disease reduction in 153 of their hospitals. And right now they're generating over 1 million patients and 3 million patient days worth of data per year. They still have relatively high admission prevalence of 15%, which is nearly 3 times what ours is. Their transmission rate's very low, 2 per 1,000 patient days, and they have had significant disease reduction throughout the system. As shown on this slide, the upper diamonds are their intensive care unit patient clinical disease with MRSA, and the squares are their non-ICU. And you can see that I put in the line for NorthShore. They and we are sharing very similar outcome results, and their disease continues to be low, as does ours. I've also highlighted the disease rates in the Netherlands, which is a country that is, as an entire nation, has taken on MRSA and driven the rates even lower. So the wider you can have your impact, or the wider you can have your intervention, it appears from the published data, the better your overall impact is. And this is from a blog that was taken from the New York Times in January of this year. Some very interesting comments. The writer was saying that the Centers for Disease Control had announced the United States was making modest progress, but the writer said progress is good, modest is not, and they go on to highlight that hospital-acquired infections is killing more people per year than car accidents and breast cancer combined, and go on to highlight the good job the VA has done. And I think this is a very good model for us as a national healthcare system, that you can have a major impact on MRSA with a well-planned and monitored program. So the next question has come up because universal decolonization has also been introduced as another method for reducing healthcare-associated infections and been also used for MRSA. And this is a summary that my partner Becky Smith and I put together in Medscape and published 2 years ago. Comparing the VA data, you can see that if you look at the final outcome, the VA has actually 3 to 5 fold lower MRSA infection rates and bloodstream infection rates than was reported in this paper, and looking at universal surveillance. And I'll talk about this, or universal decolonization. I'll talk about this a little bit more later, but it's not only important when you're reading an article to look at improvement, but also to look at final outcomes and compare that to your own data, because the studies that are done in settings where there's very high rates of disease, you may see a reduction, but it may not be as low a reduction as you'd desire. So comparing the data in the universal decolonization paper to our own NorthShore results in the New England Journal of Medicine, NEJM is the universal surveillance, NS is our NorthShore surveillance, looking at where we do targeted decolonization or targeted isolation of patients, but only those that are positive for MRSA. You can see that we looked at almost 50% of the number of patients, 55,000 patient days compared to 101,000. And the New England Journal was no screening, but decolonizing everyone. We were screening everyone and only isolating positives. The rate of MRSA clinical isolates was about 7-fold higher with universal decolonization. All-cause bacteremia was more than 3-fold higher, and the rate of MRSA bacteremia with universal decolonization was more than 25-fold higher, and our costs were actually less. So it's important, especially when you have very detailed information given in publications. It's excellent opportunity to compare what your rates are, what your costs are, and what your patient outcomes are using their kind of data or their published data in order to decide what path you should take or you'd like to take in improving patient outcome for your own individual patients. There's one last paper on chlorhexidine bathing and healthcare-associated infection published this year, again from a well-respected paper, the Journal of the American Medical Association. And this was a 1-year cluster randomized crossover trial in 5 adult intensive care units. Primary outcomes were central line-associated bloodstream infection, catheter-associated urinary tract infection, ventilator-associated pneumonia, and Clostridium difficile infections. Secondary outcomes are overall multi-drug resistant organism, clinical cultures, and bloodstream infections. And the intervention group, the chlorhexidine bathing group, had no difference in any of the primary or secondary outcomes. So it is important, as I have said already, and we'll say again, whatever intervention that you introduce to monitor outcomes and make sure that you're having an impact, and if you're not having an impact and you need to lower your infection rates, then to try something else. The big question comes, can we afford MRSA control? And this is important. We can't do things that are not sustainable in our healthcare organizations. Several papers have looked at this. This is one from earlier this year looking at the benefit of MRSA cost and control, comparing chromogenic agar with polymerase chain reaction, and they were using literature estimates of cost to look at intervention costs. They looked at disease reduction and costs averted, and I think if you look at the gain or loss, whether there was financial gain or loss, in this particular study, they were losing money on both chromogar and PCR screening. The most expensive intervention you will introduce is one that costs money and is not successful. It's likely that chromogenic agar will fail in most acute care settings because it takes too long to get the results out in order to have an impact on isolating MRSA patients quickly enough. Both the sensitivity of chromogar is less than that of PCR, and the turnaround time is longer. But even though you might have had success with PCR in this particular model, you can see it was much more costly, cost nearly $500,000 for 955 colonized patients, and that's per 10,000 admissions, and chromogar was about half the cost. But again, putting in your own cost data is helpful, and so when we first started our program, we looked at a very conservative model to estimate our healthcare costs of MRSA infection. And what I mean by that is we looked at who got MRSA healthcare-associated infections in our organization, and it occurred in patients that had a mean length of stay of 8 days or greater. So we took, in the control population, anybody that wasn't in the hospital for 8 days and removed them from the control population, and then compared patients with similar procedures, similar comorbidities, and matching as best we could with MRSA infection and without MRSA infection. You can see from this slide that just developing an MRSA nosocomial infection added $24,000 to the cost of care. If you look over to the right, the mean profit and loss was about half of that $23,000, and that is because our insurance companies, which is mainly Medicare, paid for half of the excess loss, and we had to cover the other half. So basically, the healthcare system lost about $24,000 in our patients who developed an MRSA infection. And when you plug these numbers into this particular formula that was used in this paper, and so our numbers are now what's in the PCR column, you can see the intervention costs are about the same, but the costs averted are considerably different when you actually have a conservative model of what MRSA expense is to healthcare. And we had a gain in the economics. We had a successful program, and you can see the cost benefit per 10,000 admissions was $1.5 million. So I think if you look at your own data, it's possible to it's possible to carefully decide what pathway to take in your own healthcare system. So another outcome look at of economics for MRSA testing. This looks per 10,000 admissions, and this is using the same universal decolonization data that we discussed earlier, and this was published a little earlier in 2014. Looking at 1,000 admissions and the targeted surveillance and then isolation or decolonization is in the middle column, universal decolonization on the right. And they included data on the prevalence, the number decolonized, number of days in isolation, cost of testing, room entries per day. That's important because that is what will generate your overall isolation costs. and cost of isolation. You can see that in the model here that the cost of targeted testing, active surveillance testing, and then targeted surveillance or targeted decolonization or isolation was more expensive than universal decolonization. But if you plug our numbers into it, in our own hospital, we don't have as many room entries per day. We actually now only test half of our patients, and I'll talk about that in a minute. And plugging our data into the same model that they used, the cost of targeted isolation and decolonization is actually less than universal. So again, it's important when you have well-detailed papers, put in your own numbers, take the time to go through it and see what's best for your healthcare organization. Everyone agrees that the cost of disease outweighs the cost of prevention, so we just need to decide how to best prevent disease. Medical and economic outcome, this is another important summary to look at and report to your administration when you're doing this. So we've just summarized our first 10 years of experience with our own program. We've prevented a little over 1,000 infections, had a medical expense reduction of some $20 million, 10 million net benefit to our hospital, and avoided 180 deaths or 18 deaths per year based on disease rates published by the CDC and mortality in invasive MRSA disease. So you can, I think, continue to generate organizational support if you provide these kinds of numbers to your administration. What are factors that influence costs? And I think we do have to pay attention to this in the laboratory. And one of the main factors that influences your cost of testing is specificity. And specificity difference of these 4 different ways of testing that we published on earlier this year is in the far left column. And this table generates the cost of the entire program. And you can see from this that even if you have a test that is less expensive, so the bottom test, $10 less expensive than the second test, if you have only a 5% specificity difference, it makes your overall cost of testing more expensive. So we have to pay attention not only to the manufacturer's suggested retail price or our test cost, but we also have to pay attention to the specificity, which drives excess isolation costs, and those can be very expensive. So once a population is tested and you understand it, you can actually predict quite well who is likely to have MRSA on admission and reduce the amount of or number of patients that are tested on admission. And this is another of my colleagues, Ari Robichek, did this for us and built a model predicting who needed to be tested. We validated that, and we wanted to capture 90% of the likely patients who are positive to be when they're admitted. And by generating this plot, we could see that we only have to test 50% of the patients on admission. And I think it's important to remember that for preventable infectious diseases, testing costs decline over time as the disease goes away. And so right now, our electronic health record still screens everyone for likelihood of MRSA infection, but we only test 50%, and that captures the 90% that are most likely to have MRSA colonization. And this is another summary from Illinois. Illinois publishes publicly the MRSA healthcare-associated bloodstream infection rates, and we're in the hospital in the middle here, and you can see that our rates compared to other Chicago area hospitals are 7 to 15 times lower. So when this data is available, patients can look at it and actually make some decisions as to where they want to go based on what they see as the safety of the environment. So what can you do in your own hospital now? I think you can look at whether or not you have an MRSA bloodstream infection rate that's too high. You can calculate it. You look at from the laboratory the number of persons that have positive bloodstream infection with MRSA more than 2 days after admission, calculate the annual patient days, and you can calculate your annual MRSA bloodstream infection rate. We would suggest it should be less than 2 per 100,000 patient days. If you look at all of your MRSA clinical infections, culture results, that should be less than 5 per 10,000 patient days. So these are quite easy things to do in your own hospital, and I would encourage you to do that and look at how high your rates are to determine if you have to do anything beyond what's already being done. Next, I want to talk a little bit about Clostridium difficile infection. And the pathogenesis of Clostridium difficile infection really hasn't changed since our understanding in 1998 through the most recent review in 2015. Patients receive antibiotics, they acquire Clostridium difficile, and they get disease from it. Toxins A and B are the two main toxins that C. difficile makes, and it does appear from recent work that toxin B is the major virulence factor for C. difficile, and most of the molecular tests focus on toxin B as the target, which is the appropriate toxin to look at because that is the cytotoxin as well as the major virulence toxin. Nationally, it looks like Clostridium difficile is continuing to go up and projected to go up in the United States, which is opposite the case in Europe. This is the English data where rates have gone down. Some of this may be driven by definitions of disease and how disease is measured in the various countries, but also I think it's for the U.S. it's important and imperative that we continue to look at what's happening with Clostridium difficile epidemiology so that we are able to contain it. Clostridium difficile infection is a disease by and large of elderly, and this graph depicts that very nicely from data from 2000 to 2009, where the highest disease is in the older patient. And what's extremely concerning is that the mortality rate has apparently risen considerably since in the first decade of the 21st century, going from rates of around 3% that were really the norm for many, many years, around 1999 and 2000, up to now 20% or more in some reports. This suggests not only is there more C. difficile disease, but it's more virulent in our population. And this is just a summary national mortality and cost. Again, that the rates of mortality have risen, and the estimated costs are $6,000 to $9,000 per year, with considerable overall costs in the United States exceeding $1 billion. So another society has made some testing guidelines for Clostridium difficile infection, and the most recent published ones that I've seen for the U.S. are from the American Journal of Gastroenterology, and recommending that the nucleic acid amplification tests are superior to the enzyme immunoassays, and that some of the glutamate dehydrogenase screening tests can be used in a 2 or 3-step screening algorithm, but you will lose sensitivity when you're doing this. And again, you can look at your own laboratory, what kind of testing is being done. Enzyme immunoassay as a standalone test is not very frequently used in the United States anymore. It's going to be mainly PCR or an algorithm using PCR testing that are used in the U.S. according to the most recent data. So what can the laboratory provide? I think what's important is that the laboratory can provide reliable detection of toxin-producing C. difficile, but we can't really determine whether the patient has C. difficile infection or not. That has to be a combination of a reliable test for toxigenic Clostridium difficile along with the appropriate clinical setting that has to come from our clinical colleagues taking care of the patients directly. These are the current testing options, and I just put this in here. This is from a summary on how often to test that Dr. Robichuk and I published a few years ago, but it does list on the far right-hand side the manufacturer's suggested retail costs of these various tests, and you can see that they are relatively comparable, and that choosing the best test should not be prohibited by the cost of this particular assay. Several years ago, we started looking, as well as others, at the sensitivity of various tests, and that's what's highlighted on this slide, where we're looking at the sensitivity of PCR compared to enzyme immunoassay, and in 2007, we found that PCR could have a sensitivity over 93%. Enzyme immunoassay at the time was 73%, and as I'll show you in the subsequent slides, this has gotten worse. Again, highlighting that the cost of these tests can be fairly similar, as well as the hands-on time, especially for enzyme immunoassay and real-time PCR, very, very little hands-on time for the laboratory. This is a large study that Eastwood published in 2009, and again looking at the sensitivity of various assays for detection of potential Clostridium difficile infection. What I want to highlight here is the glutamate dehydrogenase assay, or GDH, which is a component of the cell wall of Clostridium difficile. And what I'm highlighting here is that the sensitivity will vary depending on the gold standard. So when their gold standard was tissue culture cytotoxicity, the sensitivity was over 90%. When it was culture, it was under 90%. And all of this makes a major impact in the sensitivity of the two-step algorithms, where GDH is often the first step. This is another study from Novak Weekly, published in 2010, looking at very similar things. Just want to highlight the sensitivity again, and here EIA is down below 60% sensitivity, and this PCR test, which happened to be the Gene Expert, was over 94%. So as we move forward, the sensitivity of the EIA seems to be getting worse and worse. This is another study that we published looking at 1,000 non-formed stools, again testing multiple assays, and we had 146 that were considered true positives by reviewing of the chart. And we used it as a gold standard enriched toxigenic culture, so both direct plating to agar as well as to broth, and then plating again to agar. And again, highlighting this, the sensitivity of the various tests, EIAs were under 50%. We want to highlight the two GDHs, which are in the middle, 87 and 84%, and the PCRs were the commercial PCR. This happened to be the BD genome test, was 95%. So when looking at a sensitive method for detection of Clostridium difficile, the GDH has generally been found to be under 90% sensitivity. And then we started looking at kind of all of the tests together, and this is a nice review in Clinical Micro Reviews from 2 years ago, again coming up with EIAs lacking sensitivity, and detection of C. difficile in clinical specimens alone does not equate with disease. Why is EIA so inferior? Fred Tenover published a nice paper a few years ago showing that EIA lacks sensitivity for some of the ribotypes. So as C. difficile changes, we may see more and more reduction in EIA. So I want to go over some of this relatively quickly so we have time for questions at the end. But building the case for correct testing, and the issue becomes you need a sensitive test. This looks at what happens when you just repeat the same test, and with a sensitivity of EIA at only 73%, it took 5 repeat tests to actually find all 100 total true positives, but by then you had 107 false positives. EIA, therefore, actually you can't really use and just do repeat testing to try to find all the positives, because you'll end up with a lot of false positives. The real-time PCR does better, but even with taking 2 repeats to find all the true positives, you still end up with a significant number of false positives. And the impact of rapid testing, this is looking at the cytotoxin assay compared to PCR compared to a 2-step assay, and what the impact was. And basically, the more rapid your test is, the shorter your patients require to be treated, and empiric therapy decreases because your results are back more quickly. What we're starting to look at here is the impact of how you test. What difference does it make what test you're using? Do you get too many false positives, true positives? And this is looking at another study where they reported complications occurring within 30 days, and they were specifically looking at what combinations of tests gave you complications, in trying to decide what tests actually were really telling you who had Clostridium difficile infection and who might be colonized. This study also looked at the time to detection of an outbreak, and in this study, this slide, the lower line graph shows EIA and the incidence of C. difficile infection, and you can see that it took longer to cross the threshold of 0.9 per 10,000 patient days of infections, which was the government-imposed threshold. So you actually, when you did EIA testing, it looked like your hospital was doing better, but eventually you got up to the high rates of disease and didn't recognize there was a problem as early. And this is another study. This is looking at their data from PCR positive only, and that would be EIA negative, PCR positive, and EIA and cytotoxicity both positive. And the differences, and you can see that there was a higher mortality in the patients that had both PCR and EIA positive, and there were more readmissions and more complications, but it wasn't totally negative in the PCR only. And this is an early suggestion that the PCR positive onlys did have disease, but maybe just not as severe disease. This is a study out of England looking at the same thing, looking at GDH toxin and toxin gene tests, and they separated it into 3 groups: those that were cytotoxin positive and culture positive, cytotoxin negative and culture positive, or both. And they had a large number of samples, over 8,000, and this is their data. And what you can see here is that death occurred most frequently in the all test positive versus all test negative, but the patients that were either cytotoxin negative and culture positive or cytotoxin negative and NAT or PCR positive were intermediate in the findings, and the only mortality difference was for all test positive and all test negative, again suggesting that the patients with more severe disease had all of their tests positive, but you still have true patients with Clostridium difficile infection that are PCR positive or culture positive only, and not cytotoxin positive. This is the final study looking at this particular same question, and all-cause mortality in the second bullet was higher in the EIA positive and PCR positive than for the EIA positive and or EIA negative and PCR positive, but it still did occur. Persisting diarrhea was also worse in the all test positive. So EIA positive strongly predicted death and diarrhea, but PCR positive was still associated with disease. So can the specimen prevalence really help you as a specimen, as a quality measure? And we looked at this in particular to see what your levels of positivity should be in the laboratory for PCR and EIA. And it looks like your PCR positive rate should be about twice that when you were using EIA, and PCR positive prevalence should be monitored. If that's not satisfactory, you should look at things. Cliff McDonald from the CDC and I did a program for State Health Department, and this was our suggestion that when you're using EIA, the prevalence of positive tests should be 10 to 15%, when PCR it should be 15 to 20% more, and if not, look to see that your lab is rejecting foreign stools, and also make sure that your clinicians are ordering tests only on those patients that truly have the right setting for Clostridium difficile infection. And this is looking at our own data again. You can see when in the left, when we were using EIA testing, our positive test prevalence was 7.5%, and when we switched to PCR, it was 16.7%. Economic analyses have been done looking at this. This is the first large comprehensive study on this, looking by Schrader, published last year. And on-demand PCR was most efficient if the case that you missed were costing more than $5,000, or they resulted in 2 or more transmissions. So the question being asked here is, if you do a slower test other than a real-time PCR assay, does that mean you're going to have more spread in your hospital and more disease, and eventually more cost to your healthcare system by missing these tests? And this particular paper seemed to say yes. This is another paper that was just published earlier this year, suggesting the 2-step algorithm was superior, but they used a glutamate dehydrogenase sensitivity of about 94%, which meant you don't miss many patients. So if you use a sensitivity in the 80s, that will change these results. So again, in reading these articles, it's very important to know what numbers go into the models that are being developed. So testing options, financial testing options. This is a way of figuring out, can you afford to do PCR C. difficile testing? And in the U.S., it's typical for patients to go into isolation as a precaution when a C. difficile test is ordered. And we discussed this with our infection control program. And when we were able to offer PCR testing for C. difficile 24 hours a day, 7 days a week, they were willing to wait until the patients had a positive test with going into isolation. So by doing this, we had 88% of the tests were negative. Patients did not need to go into isolation. And the bottom line was, by saving all the isolation costs, we could spend up to $43.63 per assay and still come out even or ahead in cost by doing a PCR test, and avoid all of the unnecessary expenses and patient inconvenience and healthcare worker inconvenience of putting people into isolation. So for MRSA, you're really using PCR to try to get a rapid result back, rapidly isolate patients and avoid disease, and justify the cost that way. For Clostridium difficile infection, you're avoiding unnecessary isolation costs, which is can be a very large expense and can justify your test cost in that way. Pattern of an outbreak, just briefly, C. difficile tends to be endemic at low levels, and as demonstrated on this slide, when a new strain comes into your healthcare setting, you may have outbreaks, and the sooner you recognize this, the better off you are, so you can control the outbreak and it will go away. Very interesting paper published this year looking at EIA and PCR detection of outbreaks. And as you can see from this paper, the PCR detected more healthcare-associated infections and actually told them that they were above a threshold and having an outbreak, whereas the EIA, if they had been using that, would not have found or even detected the outbreak and had not alerted them to the problem. So it does suggest that sensitive testing can be useful both for detecting all patients with Clostridium difficile infection, as well as for detecting outbreaks. Briefly, I just want to finish with this slide, these 2 slides showing that when you have a high level of disease, and the third column from the left is our healthcare-associated CDI rates for our hospitals, our 4 hospitals. In 2012, we wanted to get the rates down. We actually tried 4 different interventions in our 4 hospitals and then combined them all in 2014, and by doing so, we reduced our C. difficile infection rates to very, very low levels, to 6 per 10,000 patient days, which equates to 2.4 cases per 1,000 patients. And this is just a graph of this. And if you look at the curves, the two curves where we were doing all interventions and where we were monitoring cleaning with environmental services and using glow germ on the wall, and then re-cleaning the room if it wasn't satisfactorily clean. Those two interventions both reduced disease, whereas enhancing hand hygiene and changing to a sporicidal cleaner did not. So what the takeaway is from this is to make sure that you decide what intervention you want to do and then monitor the outcome, and then change what you're doing if you're not having the desired impact. So reducing C. difficile infection benefits isolation of expense, malpractice claims, impact hand hygiene, or impacts detection to improve control. And in the U.S., it will help you avoid Medicare, or what's called now CMS, fines, which are a condition of participation and important for hospitals to avoid. You can calculate your own rates. You can look at, again, the number of persons in the hospital for 2 or 3 days after admission with 1 year with onset of Clostridium difficile infection, and the number of annual patients. And if your Clostridium difficile infection rate is greater than 5 per 1,000 admissions, you really should look at your healthcare practices and do what you can to lower those rates. So to summarize, molecular testing can play a critical role in controlling healthcare-associated infections. Financial implications on how you justify this will vary with disease. The role of rapid diagnostics are revolutionizing our practice and treatment of healthcare-associated infections, and we need to work closely with innovative industries as well as government to achieve the final goal of improving patient care. And my own personal feeling is it's crucial for the laboratory to be visible to our quality improvement and risk management partners so that benefits that are accruing to our organization are recognized and we're given the necessary support. Thank you very much. I'll try to answer any questions.
Thank you, Dr. Peterson, for that excellent presentation. It's now time for Q&A. Before we get started, I'd like to remind everyone how to submit their Q&A comments and questions. Just click on the green Q&A button at the lower left of the presentation window and click on Send. We'll get to as many questions as we have time for. Our first question comes from Elizabeth McDaniels. Her question is, what is the possibility of comparing quantities of C. diff in stool to quantities of usual flora to determine presence or absence of infection with positive C. diff test?
I think that's a wonderful question. It's difficult with using just regular culture because trying to define what normal or usual flora is using routine clinical microbiology cultures is probably not doable. This is being carefully looked at using deep sequencing as part of the gastrointestinal microbiome project, and clearly there are patterns of stool that are abnormal that you see with C. difficile, and then they return to the more normal picture or pattern when C. difficile infection resolves. So this is being looked at, and right now it does appear that there are a few organisms that are critical to maintaining a healthy flora to avoid C. difficile infection, but that is probably content for another presentation 2 or 3 years from now.
Our next question is from Jacques Netherland, the Hill Country Memorial Hospital Lab. Do you have any data reflecting the newer PCR testing for C. diff, including the Illumigene and AmpTheView?
We haven't used those in our own laboratory, and basically what I would recommend for anybody looking at this is to take, if you want to really compare kind of apples to apples, if you will, identical data, either compare what's in the package inserts or compare with what is in the published literature for the various assays, and look specifically at sensitivity and specificity, trying to get over 95% sensitivity and over 98% specificity. It's a challenge. Most of the molecular tests have that test performance, but if there's a variation in when you're comparing either the package inserts or what's in the published literature, then you have to take that into consideration depending on what assay you're using. As I mentioned in the talk, the assay performance is really predicated on what the gold standard is used. And for tests in the United States right now, the Food and Drug Administration is requiring an enriched culture for Clostridium difficile and for MRSA assay development. So what this means is that the specimen's plated on regular, usually selective agar, and then also put into broth, incubated usually overnight, and then put onto more selective agar, looking for the organism in question.
Well, thank you. Next question from Lillian J. Gomez. Regarding the assessment of clinical relevance of a positive molecular test for CDI and outcomes, in other words, death rates, did the patients receive the same therapeutic approaches and had the same comorbidities?
That's another excellent question, and generally you don't get that level of granularity in the multi-center trials. So the short answer of that is no, we don't really know that data, and so you'd like to look at studies that are more broad. We've just finished a large study of our own where each patient was interviewed and tried to determine clinically whether there's a C. difficile infection present. It's very, very complex, and unfortunately C. difficile has a spectrum of disease from mild to very severe. Patients in the hospital are often on laxatives, some are on stool softeners, some are receiving enteral feedings, and so you have a lot of diarrhea, excuse me, that isn't well defined. And ideally we would have that kind of data, but for most of the published literature it's not existent.
Thank you, Dr. Peterson. Let's give one more minute for anyone else who might have a question or comment. If you have another question for Dr. Peterson, please send it in now. If there are no more questions, I'd like once again to thank Dr. Peterson for his presentation. Dr. Peterson, do you have any final comments you'd like to make?
Just one. I saw there was one last question that came in on point-of-care testing, and I think this will be the next revolution, if you will, in the microbiology revolution we've all been going through for the last 10 years. What's very interesting is assays become more miniaturized, they get faster, and so some of the point-of-care assays, molecular tests, they're still real-time PCR assays, or based assays, will provide answers in 20 or 30 minutes with the same test performance as the traditional real-time PCR. So I think that's the next thing to keep an eye out for. Again, look at the quality of the data that's being accepted for release of these assays by the regulatory agencies. They don't always have the same reviewers, and sometimes the quality of the data isn't as good for all of the test products. So it's important for the medical and clinical microbiologists, those of us that are deciding what tests to use, to not only look at the summary data in the approvals, but also look at how the statistics were performed, how large the data sets are, and whether we agree with the conclusions that are in the package inserts.
Okay, excuse me. Well, once again, Dr. Peterson, I'd like to thank you again for your presentation today. And I'd like to give special thanks to the audience, as well as our sponsor, Roche Diagnostics, for making it possible to bring you this presentation. Before we end, today's webcast will be available for on-demand viewing through February 3rd, 2016. You'll receive an email from us alerting you when it's available on demand and posted on lebroots.com. You're welcome to forward this announcement to any colleagues who are able to join us today. Thanks for logging on and participating in today's broadcast. Until next time, goodbye and thank you.
Thank you.